Let's switch gears a little bit. This is now a younger patient. Roy, we'll start off with you. 46-year-old woman presents with dyspnea on exertion, right-sided rib pain. Chest x-ray shows a left upper lobe mass, 3 centimeters, suggestion of hilar and mediastinal adenopathy. There's clearly a lytic lesion in the rib. Further workup, CAT scan and PET confirm these findings, show other areas of osseous metastasis. Patient undergoes MRI of the brain, which is negative. Somewhere along the way, she's also undergone a bronch-EBUS, and the pathology shows adenocarcinoma. It's been sent off for the usual panel that we would typically look at in this situation, EGFR, ALK, and even ROS1, all are negative. They've thrown in KRAS as well, since patient's a heavy smoker, 30, 40 pack years. That's negative. How would you manage this patient?
Right, so this, I guess, we used to call this our triple negative patient, but I guess now with RAS1,
it might be quadruple negative.
Quadruple negative. But, hopefully someday we'll find new drivers or new gene pathways that we can target. But, this patient, with her performance status as it is, she's quite young, would be a candidate for platinum-based therapy, and there are a number of options that we can offer. Certainly, pemetrexed would be part of my combination, and I would clearly recommend carbopemetrexed. Looking at her with her performance status, I probably would add bevacizumab as well. And looking at the Point Break trial, I think you could justify it based on those data. So I'd probably give pemetrexed and bevacizumab.
Karen, do you agree with that, or do you think that combination is going to break the bank?
So I think that when we're thinking about giving a combination, we need to think about toxicity, we need to think about the efficacy involved, and we need to think about cost. And in thinking about the Point Break data, carboplatin, paclitaxel, bevacizumab, followed by bevacizumab, had similar outcomes to carboplatin, pemetrexed, bevacizumab, followed by pemetrexed and bevacizumab. When we add both pemetrexed and bevacizumab to a regimen, we're thinking about an extra $7,000 per cycle and potentially over $300,000 of quality life.
If you continue the maintenance
right?
therapy beyond. Right.
And this is in a regimen that has similar efficacy. And so looking at the data, it's hard to justify that.
So you would probably default to a taxane combo if you're going to use
if using
bevacizumab,
and if not platinum and
pemetrexed alone, and not necessarily use the bev.
Exactly.
Anne, your thoughts?
Well, so I actually do have a little bit of a different take on this. I mean, I think we also have the AVAPRIL trial, which showed that the addition of pemetrexed to maintenance with bevacizumab was better than bevacizumab maintenance alone. And so I think the jury's still out about whether or not what is the optimal maintenance treatment for these patients, whether it's dual maintenance therapy versus single. And so E5508, which is a prospective trial, should hopefully give us a little bit more information about what is the best way to handle these patients. Now, the decision about whether to do bevacizumab or not up front, I usually do tend to use it. In the Point Break trial, it did say that there was a little bit more toxicity in the carbo-pem-bev arm. I have to tell you, in my clinic, I don't see that at all. I mean, this is usually a regimen my patients really like. They don't have the neuropathy, they don't have the alopecia, and I didn't see...
They don't look like cancer patients.
They don't look like cancer patients, and they do very well with it. So my personal experience with the regimen is actually quite favorable, which is why I like to give it to my patients.
Can you just recap the study design of ECOG 5508?
Yeah, so it's basically starting off with the E4599 regimen, which is carbopaclitaxel bevacizumab for 4 cycles of therapy, and then patients are randomized into one of 3 arms, and one is pemetrexed alone, the other is bevacizumab alone, and the other one is the pem-bev combination as maintenance therapy.
So the pem-bev, as you pointed out, in AVAPRIL seemed to have had a clear-cut PFS advantage. There was a slight difference in survival favoring the combination. It wasn't significant, though.
Right, but I think clinically significant progression-free survival is very important to patients as well.
Everett, your take on this sort of situation?
Well, I think this is complex and various items that could be discussed. I want to maybe comment on AVAPRIL first. Since the way I read that trial, it's basically a repeat in a BEV-positive population of JMEN. So you give maintenance pemetrexed added to what patients were giving or taking before, and instead of nothing, they have bevacizumab, since that's built into the parent regimen, And then there's a progression-free survival advantage and a marginal impact on overall survival. So it seems to me very similar to other maintenance trials that we've had, and certainly not specific for bevacizumab. Given the other choice, let's put survival over economics, but both should count. And the survival data don't guide us very well. So what we know is 4599, added bevacizumab to carbotaxol, very important. Proof of principle, survival is prolonged. It stands as a triplet regimen, but taxane-based. As this is followed, a phase 2 study is done that adds bevacizumab to cisplatin or carboplatin and pemetrexed and has favorable phase 2 data. And the logical next question would have been to compare that triplet against the doublet, which eventually was done in the pronounced trial to isolate the bevacizumab effect. And similar, you could ask, how does this triplet now compare against the taxane-based triplet? And those data don't show one to be superior. That's where economics come in. And that is where Taxol then, I think, is superior because it is, best as I know, less expensive to administer.
So your argument would be if you are including a regimen that has bevacizumab, once it comes to maintenance, if you're going to choose maintenance, it would be single-agent bevacizumab and not the combination.
If it was Taxol-based, and otherwise it would be pemetrexed.
Alone,
Yeah.
and stop
Yeah.
the bevacizumab at that point.
Yeah.
Ironically, we don't really have any isolated data for bevacizumab maintenance. The 4599 trial was part of the package. They got it concurrently with chemo, and then they continued it, and there was, in fact, a sort of post hoc landmark analysis that did isolate about a 2 or 3 month survival advantage when you looked at folks who hadn't progressed on both arms, but there's never been any prospective phase 3 trial
Which is
that's isolated.
why E5508 is so important, to take a look.
I think purists would argue that maybe 5508 is missing an arm, that there should be a control arm of observation.
That's fair, but it's
Karen,
the best
what's
we
your
have right
thought?
now.
I mean, I think that the data with pemetrexed, though the trials are not perfect, as Everett mentioned, the JMEN trial that looked at carboplatin plus a second agent that was not pemetrexed, followed by pemetrexed maintenance or placebo, and patients had both a progression-free and overall survival benefit in that study, although most patients didn't receive second-line pemetrexed. But when you also look at pemetrexed containing platinum pemetrexed first line, followed by pemetrexed in the Paramount trial, you also have a progression-free survival and overall survival benefit, which is important, which really shows us that pemetrexed is an important maintenance drug. Whether bevacizumab is as important, I think, is unclear.
We do have 2 separate prospective trials that have shown a clear survival advantage, although there are flaws to the trial, but a clear survival advantage for pemetrexed maintenance therapy.
Exactly.
We don't really have that for bevacizumab. So I think that's an important point.